Just wait. Starting 2 minutes time.
No, now I cannot see any question.
Now,
I can see your screen, but not the question.
yeah. So just wait. Starting a timing.
Okay.
One more slide I will be showing you.
Later or now only?
Now only one more slide I will be showing.
Okay, ma'am, sure. Okay, ma'am, first page. I start, ma'am.
30 seconds more.
Should I start?
Start.
Hello, I'm Dr. Rajni, one of the doctors in the gynec clinic today. May I know your name and age, please?
I'm Amy Lonsdale and I'm 35-year-old doctor.
Nice to meet you. What would you like me to call you?
Call me Amy.
So, Amy, what I can gather from your notes is that you have some pain in your tummy and with your periods, right?
Yeah, doctor.
So, what are your expectations from today's consultation?
Actually, doctor, I have been married since last 2 years and I wanted to get pregnant, and that's the reason I am very keen. So I'm here to discuss my ways and options.
Surely, Amy, we would be trying our best to help you out. But since I'm meeting you for the first time, can I ask you a few questions to know more about you and then we can discuss the options? Would that be okay for
Yeah,
you?
that would be great. Yeah.
So, can you tell me more about your this condition?
Um, yes, doctor. Actually, I'm having this pain since quite long time. For which I had went to the GP. He has prescribed me some pills also. With that pills, it was better off. Initially, it was during my menses, but nowadays, after stopping these pills, because I am keen on getting pregnant, I'm getting this pain continuously, doctor.
Okay, I'm really sorry for the difficult time you are having, Amy. On a scale of 1 to 10, how would you grade this pain? With
Yeah,
10 being
doctor. Yeah, when it is my period, I do have to take my leave from my work. It is affecting me that badly.
okay. Really sorry about it. Does it travel anywhere?
No, it's not traveling. It's in the lower tummy, doctor.
And what makes it better or worse?
Uh, no, actually, once the periods get over, then that pain gets dull aching. It is not that severe, which will not affect my quality of life.
So any problems with your waterworks or back passage?
Nothing, doctor.
Okay. And so, Amy, a few of my questions would be sensitive, but it would help me in knowing you better. Is that okay if I ask you?
Oh, yeah, that's great.
So, so as you said that you, since how long have you been with your partner?
Yeah, we are married since 2 years, and since last 6 months, I'm planning to get pregnant.
And any other partners did you have other than your current partner?
No, doctor. Why actually?
No, I just wanted to know that did you have any history of sexually shared infections in either you or any of your partners?
No.
And any problems at the time of sexual intercourse?
Oh, yeah, that is also one of the problem, and that's the reason I just want to avoid my sexual intercourse. It's paining a lot, doctor. It's paining a lot during that intercourse time.
Okay. And and how has been your periods?
My periods are pretty regular, but recently I have noticed that it is little bit more.
And when was your last period?
It was 2 week back.
And are you updated with your cervical screening?
Yeah, I'm updated.
And have you ever been pregnant prior?
No, never.
So, are you on, as you said, you have taken some medications. Are you currently on any medications now?
I have been on folic acid. Apart from
Okay. Hello?
I have stopped COC. I am been on oral folic acid.
I'm screen disappeared. So, otherwise, you're fit and fine.
Yes, I am fit and fine.
So, any allergies you have?
Yeah, I'm allergic to penicillin, so I avoid penicillin because I get rash. It's not that severe.
I'll document this. So, any reservations for blood transfusion if at all required?
No,
And any surgeries you have had?
no.
Any family history of similar condition or any cancers, clots?
Nothing, doctor. I don't think my family member was having any of such condition.
So have you felt depressed or low in the past few weeks?
No.
And how is your support at home?
Yeah, my husband is quite supportive.
So a few questions regarding your lifestyle, Amy. Do you smoke or take alcohol?
No,
And may I know your weight to height ratio?
it's normal.
Okay. So can I examine you in the presence of a chaperone? My nurse would be taking your pulse and blood pressure. I would be having a look at your tummy and maybe down below. Would that be okay for you?
Yeah, doctor.
Okay. Uh, s- um. So, Amy, I have I can see that you have had some tests done as well, right?
Yeah, doctor.
Okay. So I have confirmed your name and NHS number on the reports. And ma'am, I can't see the screen. And um, your report shows that everything is normal, but it shows that there is a blood filled sac which is present in your left ovary.
Okay, okay.
So, based on your history, examination, and the investigations, it appears to us that you have a condition, what we call it as endometriosis. Have you ever heard about it?
No, doctor. It is something to worry about. Is it serious one?
So, I would like to tell you that this condition, the exact cause is not known, but maybe sometimes because of the some genetic problems, or maybe some like immune problem. So what happens is the tissues of the menses, they spread in a backward direction through the tubes and gets deposited in your tummy. So what happens is they will also behave like the inner lining of the tube, how it is shed. But since those tissues elsewhere, they do not find a passage to be shed, so they get trapped, and that is why there is a stickiness there, and leading to inflammation, which is causing your pain, as well as pain at the time of sex and during periods. Am I making myself clear?
Yeah, doctor. I'm worried about means with this pain, how to go ahead further then?
Your concerns are very valid, Emil, but don't worry, we do have options for you. So, since and the ultrasound has also shown the sac, which is which is because of this condition as well. So, what you can do is you can have a healthy lifestyle, keep yourself active, and engage yourself in exercises, as well as avoid wheat products and dairy products. So your care would be taken by a group of doctors known as multidisciplinary team, and that would include like my consultant. This would include the radiographers. It would include the bowel doctors, the bladder doctors, and the counselors, and the pain doctors as well, and your GP, as well as the social worker as well. So we do have options, like we can give you medications, and we can give you surgical options as well. But in the medications,
So
am
I
I
can go
making
ahead with medicines, doctor, then.
so Amy, I would like to tell you that for medicines, most of the medicines what we have, they since you're wanting for pregnancy as well, so most of the medicines what we offer is prevents the release of the egg, and it would hamper you in getting pregnant. Am I making
Okay.
myself clear?
Okay. So then what is the next line of management, doctor?
So since the cyst which sac which has been formed is quite big in size, so the team would decide whether it needs removal or not. So there are pros and
Okay.
cons of the removal. So like, see, removing that would definitely benefit you in terms of your pain, and also it would help you in getting uh, you know uh, pregnant as well. And it can even prevent the recurrence of it having again. But at the same time, it does have some disadvantages, like there could be risks of anesthesia. There could be risk of surgery, like surgeries, like since this would be done by mostly by a keyhole surgery, what we call it, where a small cut would be given into your tummy, and the camera would be inserted into your tummy, and the inside of the camera would inside of your tummy would be visualized on a screen. Am I making myself clear?
Yeah, doctor, quite clear. So what are the
So
complications if
yes,
I decide to go
the
ahead?
complications that can happen is there could be risk with surgery. Like, what happens sometimes, there is difficulty in entry, or there could be risks, the bladder, the bowel, sometimes they get injured. There could be bleeding, there could be infection, and these are I'm not trying to scare you, but I'm just trying to inform you that these risks sometimes gets increased more because of the inflammation and stickiness that has been formed because of this condition.
Okay.
And
Okay, got it,
sometimes
doctor.
what happens is, while removal of this sac, there is even a possibility that the ovary in which it is present might get affected in an adverse way, so leading to decrease in the quality and the quantity of your eggs.
Okay, okay. Then what, doctor? Then how I'm going to go ahead, and I wanted to get pregnant.
Yes, Amy, I do understand your concern. So I can even, the multidisciplinary team would decide what they can offer you. Maybe they can offer you an appointment with the fertility clinic, where they might propose you to remove some eggs before this procedure, and then try to remove this sac.
Okay.
And after this surgery, chances of conceiving are very high. You can try in the next 6 to 9 months, and in case if you are successful, then it is in case if you are successful, then since the chances of pregnancy is very high, and even if when you get pregnant, the symptoms what we have will get mitigated.
Okay, okay.
And in case if you do not get successful, then in that case we might have to offer you to the fertility center uh, for taking forward through what we call it as test tube baby.
Okay. Yeah. Okay, sir.
Am I
Doctor got it. Yeah. So I decided to go ahead with surgery.
Okay, so one more thing I would like to tell you, Amy, that when you are pregnant, so because of this condition, there could be possibility, and there is a possibility that there could be some miscarriage happening, or what happens is sometimes the blood pressure might shoot up, or the afterbirth might get attached, maybe in the lower side of your womb, and the baby might come early. So these are the things that can happen, and even if sometimes the baby might form in the tube.
Okay.
So I'm
Okay.
just trying to tell you the implications that can happen, so that you're well informed, Amy.
Oh, yeah, doctor.
I know it is a
Too
lot
much
of
to take in, yeah. This is too
Yeah,
much
it
to
is
take
a
in.
lot of information. I will be giving you the patient information leaflet. You go through it, and also I will be telling you the names of the support group, like what is called as Endometriosis UK. You can talk to other females in that group, who have walked through the similar pathway.
Okay. Yeah, definitely, doctor. I would like to go through that. Thank you, doctor.
Is there anything else you want me to address, Amy?
No.
So thank you
Thank you,
for your
doctor.
time. I'll be writing back to your GP as well.
Okay. Thank you, doctor. Okay. So now coming to your own reflection.
Ma'am, I didn't know the answer of this question. That is why I had.
Why? You were doing good?
Acha, I don't know, means.
You were doing good. But the only thing is time management, Rajini.
How much time did I take?
13 minutes.
Okay, ma'am, I thought it is not over, so I kept on telling, otherwise, I would have finished.
Still, you could not have finished. Your history taking timing was 5 minutes 20 seconds.
Okay.
Okay. So
So,
you
ma'am,
need to,
what were the
yeah.
like faltu questions which I could
Not
have?
faltu questions. I think that pain details. See, when I had provided you the history, means diagnosis, USG, which was showing endometriosis, then that radiation and all those things doesn't matter. You just only need to ask her what type of pain she is having, because I had given you the open answer regarding the pain, what it is exactly. It is
Okay,
the
so
like,
then I can cut short
then
and
you can cut short that history,
okay,
because you
okay.
know here that the patient is having endometriosis,
Yes, 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 ma'am.
at
Okay.
least a mass which is there.
Uh-huh.
So it
Uh-huh.
could be either a TO mass. So that STI history, I will say that it is relevant. But partner history, why you want to ask partner history? How many partner and what number of
Yeah,
partner?
yeah, yeah, yeah. I can cut short that also, because it is already given endometrioma.
No, but
Uh,
still STI history you can ask. Whether it is tubal TO mass also. STI history, I will suggest you to ask, but I will not suggest you to ask partner history. Okay.
Acha, okay, ma'am. Okay.
Okay, then means every time whenever the patient is saying, I acknowledge, I understand your concern, I understand your concern, use these sentences only thrice to show the empathy. And at a sensitive point, at a
Okay,
sensitive
ma'am.
point, when you think that this is more sensitive, I should acknowledge this. Not every time.
Okay, ma'am.
This can be also a way to minimize your, cut short your
Time.
time. Because see, you have to acknowledge their pain, you have to acknowledge their suffering, but not every time. If you will be keep on doing every time, then this will cause you your time management.
Okay.
Okay, so
Mm-hmm.
acknowledge at a sensitive point when you think that they have lost someone, when they are suffering very badly, or they're having some significant concern. If I'm having a concerns at every point, oh yeah, your concern is very valid, I will like to address that concern. Rather than saying this sentence, I will directly address that concern. You got my point.
Yes, ma'am.
You got my point. Rather than saying this sentence and cutting short on my amount of significant amount of time, I will directly address that concern and gain some extra marks. And if it
Yes,
is
ma'am. Yes,
severe,
ma'am.
then say sorry for your problem. Means you cut short your sentences, you cut short your words, so that you will take minimal time. That was the only thing what I had failed. Cut short. And then another point is explanation of endometriosis. Explanation of endometriosis was too big, too big.
Okay, okay, that I can cut short. Okay, ma'am.
You can very easily cut short because you just wanted to know that these are the tissues which are similar to the lining of
The
the womb.
lining
They
of the.
present, yeah, this present elsewhere. When they are present elsewhere in the body, we label it as endometriosis. Do not
Okay.
need to say that they will bleed, they will cause inflammation. What she's going to understand. And
Huh.
because of these tissues, because of the cyclic changes this tissue undergo, they give rise to a pain. Sometimes it will be mild, sometimes it may be severe. And if these tissues are seen in your ovary and they have formed a big cyst. That cyst you have to explain.
Okay.
Okay. So
Yes.
in 30 seconds, you can explain endometriosis and she's having endometrioma.
Mhm.
That you can cut short. I had mentioned here, cut short if possible because it was too much. MDT, then the group of specialists, yes, I had agreed. Means the management, I am agreed. Now the management, again, that management, what you made a blunder is, since you are planning to undergo a surgery, infertility treatment, I will not offer you medical line of management. See, whether it is a fertility, whether it is not a fertility, if 6 centimeter endometrioma comes to you, with family completed, what will be your approach? Symptomatic patient, dysmenorrhea, dyspareunia, constant chronic pelvic pain. What will be your approach?
Surgery only, ma'am.
Then why that medical line of treatment you said it will not be
Ma'am,
option in
I
your.
like this question. I'm literally confused. Not only for this question, but for any question. Are we
No,
supposed to? No, I'm just
no,
asking
no,
you.
no,
Are
no.
we
This is
supposed to give
yes.
all the
Yes, you
basket
are
of?
supposed to. Yeah, you are supposed to give all the options, something like that. The wait and watch and medical line of management will not be an option in your case since you are symptomatic and you are planning to get pregnant in near future.
Okay, I will. Okay, I will just tell this like this.
Yeah, so
Ma'am, I
everybody
told
listen to
medical
this.
because there were non-contraceptive options as well. So I thought I will
No,
just touch.
yes, yes. If it is less than 3 centimeter size endometrioma, symptomatic patient, and she is keen on fertility, there you can say, generally we manage this kind of patients with the help of medicines. But since in your case, you are planning to get pregnant, we would like to offer you a surgical removal of this cyst. This will be an option when the endometriotic cyst is less than 3 centimeter, to optimize and to increase the chances of having a successful pregnancy. That is what the guideline says. Yes,
Okay.
yes or no? In 3 centimeter. If 3 centimeter in other patient symptomatic, we will give her a medical line of management. More than 5 centimeter endometriosis significant, whether it is fertility conservation, fertility non-conservation, you will straight away say that surgery is a line of management in your case. These two management, wait and watch and medical line of management, will not suitable in your case.
Okay.
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 And then pros and cons and complications, because it's a big size station. Pros and cons, MDT involvement, what needs to be expected. Then very good, I really like the way you said that before surgery we will be referring, and you can cut short the sentences also. Means you were taking one sentence to explain the one thing only, that we will be referring you to the fertility specialist because you wanted to get pregnant. So I will use one single sentence. I really like the way you approach this task. That I would like to refer you to assess your ovarian reserve, and if needed to preserve your eggs. To
Mm.
For that, I will be referring you to a fertility specialist. They will discuss with you the other alternative options. In one word only, you can say. See,
Okay. Okay.
okay, we have to minimize the sentences and we have to maximize the information. So simply you can cut it short by saying, listen to the recording, what you said. Okay, you said initially ovarian reserve, and then sometimes you noted it down that you might require ovarian preservation. So whether it is possible in your case or not, fertility doctor will be saying this. So you include all these things: assessment, need for preservation of ovarian tissue or
So
eggs
I can,
will be
I in one
discussed.
line, I can say that I'll offer a consultation there, and they will assess and
They
preserve
will
if required.
assess and they will, yeah, they will decide. It
Okay.
will be
Okay.
their options and they will discuss the pros and cons of all the options. Okay, so they will be deciding. So that one question I really like, very good. I had mentioned here ovarian preservation or egg embryo, means egg oocyte preservation. Okay. So
Okay, ma'am.
overall this, then the last thing I didn't like about the task was placenta accreta, preterm labor, ectopic is okay. Why placenta accreta, preterm? Because of adenomyosis.
No, ma'am. It is told that when women with endometriosis people, they after surgery they conceive, then there are deficient implantation. So and
See, huh, okay. But here I will just say that rather than making her frightened, do not make her frightened. Her primarily treatment is this. Yeah, she will find it difficult to conceive on her own with this condition. Implications will be my implication of endometriosis as of now will be she will be having this pain, dysmenorrhea, dyspareunia, CPP, subfertility or infertility. Okay, and if she conceives, the chances of miscarriages, ectopic pregnancy will be high because the tissues are very unhealthy. Okay, so chances of these complications, but we have seen a successful pregnancy going ahead. Okay, after IVF we may have to think of taking help of IVF, we can say that also. So placenta accreta preterm label, you can say that these pregnancies will be considered as high risk and we may offer you consultant led booking to minimize the risk. But accreta and PTL might frighten the patient, that is my way of thinking. It's
okay,
okay, yeah, it's okay, means I am not totally saying it, but ectopic and miscarriages, I agree that these are the option, these are the complications. But accreta and this preterm labor, they are the very rare, means see whatever has been given in PIL we have to accept that. So read PIL of endometriosis and whatever that they had mentioned
and
in
there
that.
was a talk of this no that
See, TOG is very elaborative. TOG is very
oh,
elaborative.
oh,
Okay. So do not take each and every point of TOG thinking that, okay, this I need to explain to the patient. So this
okay,
can be skipped because I may get afraid. Oh shit, my pregnancy will. So you can just label that. Then depending upon the pregnancy, you will be offered consultant-led care unit and early USG to see the baby's whereabout and well-being.
okay, ma'am.
Okay, because you won't know that consultant led booking anyway, she will be miscarriage and ectopic pregnancy by offering her early ultrasonography. This way you can explain her.
Okay, okay,
Hmm. So that is the only way what I wanted to change. Apart from that, I don't think there was any, I mean, many other thing. One more point I had noted in your case. Mental history per se is not significant if the patient is not seeing mentally subnormal or mentally disturbed. Check her knowledge about the reports. Whenever the patient has been given any report, it's always better what she knew about her condition, what she knew about her report, so that assessing her starting point is very important. From there you have to take the stations further. Okay.
okay, ma'am.
Very good, means very well done station, but these are my feedback in this case. They had given these things, but see in our scenario it is not possible to incorporate everything into this. Okay, so I had just whatever options we had explained this to the patient can be taken into consideration. Okay, so that's the reason I didn't show this sheet. Examination and ultrasonography only I had shown it to you. I think that Rupal is having a very bad network because I am not able to admit her, or she's not able to get into the. Okay, so now coming, sorry, FGM. It is not FGM, it is endometriosis. I had not cut it short. So introduction is proper. Aim is very proper. CA, I mean, situational awareness is basically she is suffering from chronic pelvic pain. You acknowledge, you identified that it is affecting me very badly. My concerns or expectation is keen on conception. Setting agenda was proper. Open question, few close question, treatment right, history of endometriosis, AUB, dyspareunia, dysmenorrhea, and CPP. You took it out. So my other history will be vaginal discharge and STI, just to rule out whether there is any TO mass, because endometrioma it has been mentioned, but still bowel bladder symptoms you asked me. LMP smear, contraception I had given you history. Medical surgery, you acknowledge the allergy what I am having. I don't want whenever the role player don't want you to ask further question, they will in a single sentence they will give you maximum information. Okay, understand that point uh, thoroughly. Smoking, alcohol, occupation, support you had asked. Occupation you had not asked, but it is okay to miss out because it's not going to have any effect. My way of examination in the presence of saffron, I had decided not to give you ultrasonography. That's the reason I had mentioned investigation, what investigation I would like to do. So that's the reason I had mentioned investigation, but then I decided no, we will show you because it's clear cut endometriosis, so let it be. So that investigation part can be cut short. Endometriosis is your diagnosis. Means here I had just depending upon history and examination, I had mentioned most probable, but in her case now we will take it as a endometriosis. Check her knowledge whether she is aware about the report, and check her knowledge whether she is knowing. Sorry, huh? Explain endo. This is not the sentence. Okay, so explain endometriosis along with USG and offer. After checking her knowledge, explain endometriosis. Cut short that sentences when you used endometriosis. Okay, you took a significant time to explain me about
Okay, okay,
endometriosis. Yeah?
okay. Yeah.
Clinical implications. Once remember this format. Whenever you explain the condition, the cause of that condition, very nicely you had mentioned, sometimes associated with some genetic problem. We do not know the exact reason. Clinical implication also, same time you explain her that what are the clinical implication of this condition. So CPP, fertility, ectopic, affect your quality of life, and miscarriages if at all get pregnant. Okay. So management, no role of, I had mentioned, no role of wait and watch and medical line of management. Lifestyle management is only to manage her pain. Okay.
Okay, ma'am.
Symptomatic management for her pain also you can offer. Symptomatic management for her pain you can offer. Lifestyle thinking at means counselor. This pain management people and counselor can be involved in the MDT. Surgery is the mainstay of treatment. Left cystectomy, but here again the chances of oophorectomy is there. That also you need to explain because it's a big cyst, 6 centimeters. So depending upon the situation, we may need to consider removal of the whole ovary and burning the lesions in the tummy if we seen during the surgery. That is peritoneal endometriosis. That means laser ablation we may need to consider. Keyhole surgery where it is best to do into the endometriosis center. Those people who are dealing with this kind of situation day and night. MDT, you mentioned MDT components, very good. Pros and cons, risk and benefits of lap, you had explained me. Surgery may affect ovarian reserve. So if no conception within stipulated time, fertility referral for assisted reproductive procedure like IVF, if criteria meets, I had mentioned. Assessment of ovarian reserve, I had mentioned, but very nicely you had mentioned offering fertility, means ovarian preservation also can be discussed with you. I had suggested, because it's a big cyst, advanced imaging to see proximity to the ureter because it is at risk of injury during the procedure. Optimization of health, pre-anesthetist review, offer counselor, and then a plan, go ahead with the further planned surgery, which can be decided by the consultant. Now here you have to bring your consultant with MDT. They will be the deciding factor. Okay. The consultant who will be expert in doing endometriosis surgery will be doing this procedure. Documentation of her care plan is very important, which you had forgotten. PIL of endometriosis, support group of endometriosis is Endometriosis UK, which you had given. But that last 3 minutes, you have to cut it short, dear.
Okay, ma'am. Okay, ma'am.
Okay, so this
Okay.
is my, yeah, this is my way of explaining the most of the points what we had discussed were in the domain wise scoring, nothing more than that. Okay, so patients safety, patient's main concerns and ideas, read the patient's detail on the scan ultrasound image because we need to see that also. Options, pros and cons, which you had mentioned, counsel for laparoscopy,
Ma'am,
necessary
one
referrals.
I have
Mhm.
in this, like in the task in the first page, it was only written that it was not written that I'm supposed to explain the reports. So I should still explain the reports to her.
Yes, see, this is what actually we made a big mistake. Whatever we are being given, whether it is a simple diagram, whether it is a simple report, your work is or your task is to explain those reports to the role player.
Okay, irrespective of the fact that it is given in
Check,
the.
check her knowledge, whether she's aware. If she says, yes, I'm knowing, then in one simple sentence, as you are aware, you are having this condition as per your report. This way you are going to start your consultation if she is aware. If she is not, then irrespective of whatever it is there, you have to explain the report that carries mark.
Okay, ma'am.
Okay, so makes necessary referral MDT seniors with expertise in endometriosis, referral to endometriosis center after consultant input, involve patient in the process, negotiation, honest. Whenever you think that something is coming up and you are not knowing, be honest regarding that. Introducing self role, this is assess patient starting point. This is important question, dear, and which we should not miss it out. So the checking background knowledge of the patient is very important, very important.
Ma'am,
Clear
background
organize.
knowledge, what way? Like background knowledge, does she know about endometriosis? This is the background knowledge.
Yes, this is also, and does she know about the report? That is also whether she is aware about the report or not. This both question carries communication with patient and relative domain. Okay, so do not miss out on these things. Clear organization and explanation in a logical sequence, chunks, which you were giving me, which you were means that come apart from that, communication was very good, but this point you had not. My starting point you need to assess. Okay, no jargon were used. Use drawing, huh? Use drawing whenever you are explaining report. Please use drawing. This is Ori, this is Zoom, and this is a big endometria in the left side. Okay, applied clinical knowledge, history taking, significant symptoms of endometriosis, dyspareunia, dysmenorrhea, and heavy menstrual bleeding also they do have. Chronic pelvic pain and infertility. Okay. Organize investigation here already ultrasound, but still I will suggest you to organize MRI. Okay, because we are planning for a laparoscopy. We need to assess her laparoscopic. Should be aware of ovarian cystectomy is the preferred surgical option of endometrioma than drainage of cauterization because we didn't offer that. Peritoneal endometriosis, that is ablation, we can offer. Laparoscopic complications and aware of implication of endometriosis, pelvic surgery on fertility and effect on ovarian reserve. So AMH for the same needs to be considered in her care. Okay. So that way we can finish it off very nicely done, but only practice the timing what I feel.
Okay, ma'am.